join has been able to join. Thank you. Okay, good morning, good afternoon, good evening, all who've been able to join today for this important country dialogue. I'm John Barrazzo. I work at the Global Financing Facility, which is based at the World Bank. And Global Financing Facility for Women, Children, and Adolescents has really taken on the issue of ensuring continuity of essential services for maternal, newborn, child health, reproductive health in the face of threats posed by the strains on the system from COVID. And I was really pleased when USAID's Momentum Country and Global Leadership Project asked me to facilitate this and moderate this session today. This is an important country dialogue. It's part of a series, a knowledge exchange series, that is, this is the second, and today we're going to focus on child health and immunization services. It's the USAID's Momentum Country and Leadership Project is part of a suite of awards that works with country governments and local actors to provide targeted technical assistance and also for building capacity around these critical issues. We know that today's webinar focused on child health immunization services, these services continue to be required in the face of COVID. Children are still being born, children still are getting sick. So we know that they need vaccinations, they require treatment for these severe childhood illnesses, which are responsible for the majority of childhood deaths in the post-neonatal period. And some countries have paused immunization campaigns, or at least they did initially, and several have reported a decline in demand. So both the provision and demand are issues we're going to be discussing today. And we want to really be very explicit about how do we actually help people overcome their fears about service reliability, difficulty in finding transport to immunization clinics, for example, and general reduction in confidence in services and confidence in vaccines to overcome potential misinformation they may be getting. So it's really great that we've got the opportunity here from both global leaders and in-country partners to capture some of what's going on, some of what we're learning, and exchange these experiences and ensure that best practices are disseminated and adopted during what are admittedly very challenging times. So I'm going to open by introducing our keynote speaker, who is Dr. Farhana Akhter. She's a maternal and newborn health specialist in the Office of Population Health, Nutrition, and Education at USAID Bangladesh. She's been working in the public health sector for 12 years, focused on these issues of maternal, newborn, child, and reproductive health. And you can see the rest of her accomplished biography on the screen now. So without further ado, I'm going to turn it over to Dr. Farhana to launch us and give us, really set this in some broader context. So thanks very much, and over to you, Dr. Farhana.
Thank you, John, for introduction. Good morning, good afternoon, and good evening to attendees all over the world. Thank you for joining us in today's webinar, focusing on maintaining essential child health and immunization services during the global pandemic. And this webinar is convened by, as you know, USAID's Momentum Country and Global Leadership. Firstly, I would like to take this opportunity to thank all the frontline health workers who are working tirelessly to serve the women, children, and families in their communities during the COVID-19 pandemic. As you know, nurses and midwives are really playing a critical role in the outbreak response, in addition to maintaining essential health care. We know that COVID-19 is disrupting essential care, including equitable access to routine child health services and immunization programs. And these disruptions and lower rates of care seeking could stall the progress that we have made altogether and put hard-won gains in maternal, newborn, and child survival at risk. USAID is committed to ensure that essential health services continue during the outbreak and beyond this global crisis. We are continuing to coordinate with countries on the development continuum to provide targeted support aligned with national priorities and to prevent backsliding on progress to date. USAID has supported countries to build their more resilient health system for decades, including strengthening the ability to detect and respond to systems shock. That's why USAID recently launched the annual action on the call report, which highlights the critical role that frontline health workers play in maintaining essential health services. USAID has prioritized strengthening pre-service education, in-service training, and professional development and facility-based mentorship and coaching to ensure that all health workforce is skilled, competent, and motivated. In Bangladesh, we have seen much progress over the last decade, with significant decline in neonatal, under 5, and maternal mortality. Those gains are at risk of reversing if women and children do not get the critical care they need due to the pandemic. During the current crisis, USAID is providing expert technical assistance, training, commodities, and funding to improve water, sanitation, and hygiene, and infection prevention and control in health facilities as well as in the communities. USAID Bangladesh is doing to ensure continuity of essential health service and supporting government in developing national COVID response plan, national MNCH guideline for the frontline health workers, build national capacity on WASH and IPC, develop logistic and supply chain management for the government so that frontline workers should have enough and timely access of the protective equipment and logistics. USAID is supporting government in case surveillance and also strengthen laboratory testing capacity, along with service delivery re-engineering to maintain demand for services. Today, we have official representatives from Ghana, Sierra Leone, and Bangladesh who will discuss supply and demand side approaches to maintain essential child health and immunization services, and building health system resilience to address the critical gaps and challenges of the service delivery to capacity building for healthcare workers and much more. We are eager to learn what is working well and what steps still remain from our 3 country presenters. On behalf of USAID and Mission in Bangladesh, I'd like to thank you all for the opportunity to join this important conversation. Thank you all. Back to John.
Okay, thank you very much, Dr. Farhana. So one of the things I wanted to make sure that we have is one housekeeping thing. You'll note that there's a Q&A function. That'll be the principal means through which to raise issues that you'd like the panelists to respond to as we move through today's webinar. So if you have a question, put it in the Q&A box. We have people who are moderating the Q&A, and we'll feed them up to the panelists, and we hope to be able to address as many of those as possible during the webinar today. So with that, I'm going to turn it over to Dr. Steve Hodgins. Steve is on the faculty of the University of Alberta School of Public Health. He has a long-standing career in public health. He's worked all over the world. And I think you can see his extensive biography there. And he's going to really help set the stage today. And and he actually had a very a poignant editorial that came out in Global Health Science and Practice recently. And I think he's going to talk a little bit to that as well. So without further ado, over to you, Steve. Thanks.
Thanks, John. Today, as you'll soon see, I'll be making some provocative statements. I may be slightly overstating my case, but my objective here is to encourage you to think critically about big picture strategic choices for COVID. Next slide. The main question I'm going to be addressing is what should we be doing? And the key considerations are what the epidemic itself could do and what our response to the epidemic could do. And what we want at the end of the day is the least bad outcome. There's no single universal model or strategy to guide us on how to strike the best possible balance. This needs to be worked out country by country. In high-income countries, the mantra we've heard in the early phase of the epidemic has been flatten the curve, meaning impose heavy control measures to put the number of daily incident cases on a downward trend and then keep it low. So first suppress, then maintain. But as we see in the US and other high-income countries, even with a relative abundance of resources and generally pretty strong control measures, this has not been easy, and there have been considerable collateral costs. From my reading of the situation, though there may be some exceptions, in most low and middle income countries, it won't be feasible to completely contain this. There will be community spread, and we will continue to see rising incidents. But does that necessarily mean low and middle income countries will experience a high number of direct COVID-19 deaths? Not necessarily. Next slide. Now just take a minute to look at this. It shows case fatality by age group based on data from Wuhan, China. So starting from the bottom, we see that among those that are infected below age 20, risk of death is vanishingly small. Even up to age 50, case fatality is much below 1%. But after that, it rapidly climbs, reaching almost 9% for those aged 70 to 79, and 13% for those over 80. Next slide. In analysis I've done comparing Canada and Nigeria, taking into account differences in age structure, but keeping all other variables the same, per capita COVID-19 deaths in Nigeria would be more than 5 times lower than in Canada. Next slide. So as we see here, control strategy needs to be based on a context-specific weighing of, first, the expected benefits of response actions we're considering, notably on reducing COVID mortality and morbidity, versus the harms that could result from such action. And this includes harms with regard to overall health outcomes, schooling, livelihoods, food availability, and psychosocial well-being, including gender-based violence. And this balancing needs to take full account of what's realistically feasible in your particular setting. So we need to weigh on the one hand the expected direct effects of COVID, and on the other, the expected impact of our response on other areas. To minimize the direct impact of COVID-19, how much disruption is worth it? Next slide. So especially relevant for our webinar today, important reductions in the uptake of key clinical, preventive, and basic primary healthcare services are likely to result in massive numbers of excess deaths among young children. In the June Momentum webinar on COVID, Tim Roberton presented work that he and colleagues at Johns Hopkins have done using list tool-based modeling. In their most disruptive scenario, with coverage reductions in the range of 40 to 50% for key health interventions, over a period of 6 months, they determined there would be approximately 1.2 million excess child deaths. And I should point out that because of how the list tool works, this model underestimates the mortality impact of reductions in immunization coverage. In circumstances where there are no or virtually no infected individuals within a jurisdiction, so no community spread, there is a sound rationale for strict border entry controls, including quarantine or self-quarantine. And this appears to account for the success so far of control measures in some low and middle income countries. For example, in Timor-Leste and Vietnam and maybe in Rwanda. However, once there is community transmission in multiple locations, this strategy no longer makes epidemiologic sense. The virus is already inside. So under these more common conditions, radical suppression or containment may not be feasible, but it is still a good thing to slow spread, but using minimally disruptive means. Next slide. Based on evidence from case investigations to date, transmission is mostly by droplet spread and direct contact. So this is a key place for us to focus our efforts to limit spread. The highest risk is associated with very close contact over an extended period of time in tightly enclosed, poorly ventilated spaces. So riding in a packed bus produces just such conditions. Although if windows are open and everyone's wearing a face covering, things are certainly better. Even with continuing spread, there are important things we need to be doing to minimize deaths. And the most important is shielding those at greatest risk. And here we need to understand that greatest risk is different from our usual categories of the vulnerable. For example, when we're talking about gender equity and social inclusion. In this case, by far the most vulnerable group is the elderly, especially the frail elderly. But others at high risk include those known to have chronic heart and lung conditions and poorly controlled diabetes. It's worth noting that for COVID-19, children are less susceptible to infection than are adults. And those who do become infected are less likely to develop symptoms and far less likely to become severely ill. Based on the best available evidence, children have been playing a minimal role in driving the epidemic. How to adequately shield the elderly and others at high risk is not obvious. Solutions need to be developed that will work in the specific conditions we see in the multi-generation households where many elderly live. Measures need to be both effective, minimizing the risk of transmission, and feasible. For example, in most households, given limited living space, it's not going to be realistic to expect a separate room to be made available for sole use by an elderly family member. Now, despite our best efforts, there will be severe cases. So what should we be doing to get the best possible outcomes for these cases at scale? From a population perspective, in most low and lower middle income countries, I believe it's inappropriate and inequitable to give special precedence to scaling up ICU and ventilator capacity. This will benefit a comparatively small number of patients. Furthermore, providing such care is not just a matter of having such equipment, but also having experienced physicians and nurses who can safely and competently care for patients using such technology. It's worth noting that in the early days, treating severe COVID cases, there were excess deaths due to overly aggressive use of ventilators. Considerably greater benefit can be had by maximizing availability of a lower tech package down to at least district hospital level, and that would include enhanced nursing care, supplemental oxygen for all needing it, and intravenous fluids. And clearly the package also needs to include health worker protection. I believe we'll see the greatest overall benefit focusing on reducing collateral harms. In general, broad and blunt control measures will produce relatively little reduction in COVID mortality and morbidity, but great harms in other areas. What's key here is to be very targeted and strategic with restrictions on normal activities. Key areas we need to protect and maintain include health services. We need to ensure continued unimpaired delivery of both curative and preventive services. Second, food. There needs to be unimpaired access to food, giving special attention to the poor and otherwise vulnerable. Third, education. Reopen the schools. Fourth, livelihoods. We need to maintain restrictions. We need to minimize restrictions that compromise livelihoods, especially for those who depend on day labor. And last, mental health. We need clear, accurate, calming messaging to the population, delivered by spokespersons the population considers trustworthy. Three other areas needing special attention: shielding the elderly, minimizing super spreading conditions, such as public buses and aggregate living conditions like prisons and barracks. And lastly, quickly strengthening the capacity of district hospitals for care of more severe COVID cases. And one concluding point: we may not ourselves be the decision makers in high places, but we need to take advantage of our contacts and our credibility as health experts to attempt to influence those decision makers to adopt more sensible policies based on the actual situation we face on the ground, including the real risks of COVID-19 in our setting and the real and very substantial risks associated with heavy, unstrategic control measures. Next slide. So in the format for today's talk, I've not been able to give citations for most of the statements I've been making. For those who are interested, check out my editorial commentary here. Note that other than the statements Other than statements made on evidence that's emerged over the last few weeks, the points that I've made today are backed up with references in this paper. Thank you.
Okay, thank you very much, Theo. I think you've done a great job setting the stage and, frankly, taking a very holistic view towards what we're trying to ensure are the positive outcomes, not only for children in the face of COVID, but for the entire populations. And so, with that, I think it makes a lot of sense where we're going with this webinar, which is now to turn it over to several presentations from country speakers who are living this and really will talk with us around what the experience has been over the past 6 months, how things have evolved, and also take on board this when we get into discussion later, to take on board the ideas that Steve has put out there about looking holistically at how do we actually treat all dimensions of physical and mental health in the face of COVID. So I'll turn it now over to Dr. Mohammad Shamsul Haque, who is the line director for maternal, neonatal, child, and adolescent health at the Ministry of Health and Family Welfare in Bangladesh. And I think that Bangladesh has had a very interesting experience with this, and I'm looking forward to his remarks. So I'll turn it over now to you, Dr. Shamsul. Thank you.
Thank you, John. Assalamu alaikum to all. It is a great pleasure to be part of this discussion today, and I want to thank the organizers for this initiative. I will be talking about Bangladesh health sector response for COVID-19 pandemic to mitigate disruptions of child health and immunization services. Bangladesh Ministry of Health and Family Welfare provides health services in multiple tiers. The base of the triangle is community level service delivery from fixed facility known as community clinic, outreach immunization center, and domiciliary service. Sub-district and above facilities provide curative care plus essential MCGL care, including immunization services. Next slide, please. In this COVID situation, Bangladesh had a lockdown from March 26 till May 31, resulting in service disruption of immunization and childcare. April was the worst hit month. About 1.8 lakh, that means 0.18 million child, missed vaccine because 9% fixed and 38% outreach immunization center was postponed. The MR campaign was also postponed. Care seeking of sick children under 5 years of age for IMCA diseases such as pneumonia and diarrhea also reduced. Overall immunization service was more affected at community level than fixed site. In contrast, IMCA service disruption at community level such as community clinic was less than IMCI corner of facility level. Next slide, please. Here we are showing the effect of COVID on EPI coverage during January to June 2020. In January, the average immunization coverage was near about 100%, which declined to as low as 60% during April. This is due to the effect of lockdown from March. We did several activities from May to overcome the situation, which I will talk about the next slide. All the measures undertaken has resulted in gradual increase of EPI coverage during the month of May to June. We will continue our efforts during the rest of the year to sustain high coverage and reach the left out children. Next slide, please. In this period, when we faced a serious disruption in immunization and child health services, we developed a mitigation plan to overcome the situation. The key measures that we undertook are developed and circulated guidelines on how to conduct and continue vaccinations and IMCA services adopting IPC measures during COVID. This contains a flowchart on vaccination at outreach immunization center and also in community clinics in COVID. Critically reviewed DHIS2 data over the period to understand the situation and take necessary measures. We undertook an intensive monitoring across the country through increased supervision from local and central level and suggest measures. Other activities are uninterrupted supply chain management, capacity building of providers on operational guideline, etc. Mobile phone was used to track children and vaccinate them. We also utilized EPI network for COVID sample collection and transportation tool lab, distribution of sample to logistics such as PPEs, ice line, refrigerators, including masks and sanitizers. A flu corner at each health facility is established, and we introduced a triage mechanism for all patients attending the facility. Next slide, please. To maintain demand and keep the public aware, specific messaging on IPC, immunization, nutrition, safe delivery, and childcare are communicated during daily national briefing of COVID situation. We have also taken an innovative initiative known as Muktopath. Muktopath is an online hotline for COVID management and counseling with specific messages on IPC, immunization, nutrition, childcare, delivery, etc. This entire thing is done by voluntary services by doctors. As of June, we have received total 16 million phone calls. Over 16,000 doctors were trained and more than 4,000 doctors are giving voluntary phone services. There is auto-generated pre-recorded messages on IPC with every phone call. Communication materials with a specific message on IPC, immunization, nutrition, and MCGL have been developed and distributed to increase service utilization during COVID. We have also used traditional messaging methods such as announcements through loudspeakers or micings. Next, please. To create an enabling environment, we have commitment, ownership, and government leadership in governance and management of the crisis. We have undertaken formation of interdepartmental committees for MNC's guidelines, coordination, integration, and stakeholders alignment has been increased as well. Strategic guidance has been developed for adaptation of COVID response with existing immunization for child health care services and IPC services. Next slide. You can see different kinds of strategic guidelines such as immunization site operation guideline, MNC service delivery, and also communication materials for awareness development of client as well as appropriate use of IPC materials by service providers. These have been developed for COVID adaptation. Next slide, please. Here we are showing the guidelines, also the flow chart of the at different level. And next slide also, you can see that the guidance of essential service delivery from community clinic. And next slide. Next, please. Here is the posters developed during the COVID situation for the EPI corner or like the outreach center. You can see these three posters has been distributed in the remotest area also. Now, next slide, please. Next slide. Routine immunization service in FDMN population in Cox's Bazar has been established since July 2018. So far, we have conducted 10 vaccination campaigns, ensured vaccination at registered camp and no man's land. We have close and frequent monitoring mechanisms in place, provide supportive supervision, and have strengthened VPD surveillance and outbreak response activities. Next slide, please. We will develop a catch-up plan for immunization at fixed sites and outreach immunization centers, IMCI services and neonatal care at facility and community, and also improving the MNC services. We will conduct performance monitoring using data at sub-district and district level for immunization coverage and IMCI services. We will continue to ensure that there is uninterrupted supply of IPC materials, vaccine, and medicines. The communication activities for care seeking and awareness raising have given us great results. So we will continue to do that. We are also developing a detailed action plan to conduct the MR campaign, which got postponed already. Next slide, please. And this is the last slide. Though this has been a critical time for Bangladesh, our Prime Minister is very much concerned about this as she is heading the vaccination program. Bangladesh is coordinating with global activities for COVID vaccine. Honorable Prime Minister also attended the Global Vaccination Summit. One of the local pharmaceutical company is in the race of COVID-19 vaccination trial. Thank you all, and back to John.
Thank you very much, Dr. Shamsul. As I said, it's been a very interesting experience in Bangladesh, and just to highlight the recovery from essentially where services had really taken a strong hit, but be able to reorganize and to come back with effective planning, effective communications, to actually help to restore those services and to have concrete plans for moving forward. I think it's been a fascinating experience in Bangladesh. So thanks very much for sharing that. Our next speaker is Dr. Isabella Sago-Moses. Dr. Sago-Moses is the Deputy Director of the Family Health Division in the Ghana Health Service, and she is a child health specialist, and because previously she was the National Child Health Coordinator for the Ghana Health Service for more than 15 years. So she has some keen insights into what the challenges are and what can work going forward to try to maintain services and maintain the health and well-being of children. So I'm going to turn it over to you now, Dr. Sago-Moses, and look forward to your remarks. Thanks.
Thank you, John. I bring you all greetings from Ghana, and I'm delighted to be sharing with you what we are doing here to maintain service continuity during this period of COVID. My presentation will be focusing on services at the primary healthcare level. Next slide, please. I'll briefly touch on the impact of the pandemic on health services, measures that have been put in place to mitigate the negative effects, including strengthening the enabling environment, modifications that have been made, and how we are maintaining demand for services. I'll end by sharing some initial results from an in-depth assessment that is still ongoing. Next slide. The detection of the first 2 cases of COVID-19 in March in Ghana was met with great fear among the general public, and health workers were also apprehensive. Some MCH staff were redeployed to assist with contact tracing as part of the response. Between March and April, 2 major cities that were hardest hit were locked down in an effort to control the spread, and the net effect of this was low patronage of health services in general, with a greater impact on preventive promotive services like immunization, growth monitoring, etc. We had to postpone mass polio vaccinations that had been scheduled in response to outbreaks in some regions of the country, and also postpone a scheduled yellow fever mass campaign. Next slide. So this slide gives an indication of the extent of disruptions in services. If you focus on the last row for now, you see the reduction in the number of children seen at child welfare clinics. That is far below what was recorded during the same period in 2018 and 2019. Next slide. Overall, it's estimated that 33,000 children were left unvaccinated during the first quarter of the year, and this represents 11% of the number targeted. Next. In order to prevent further disruption in services, a number of steps have been taken. Various guidelines have been developed or updated to address COVID-19 specific issues. The photo you see on the screen is that of the document that specifically outlines strategies for ensuring that maternal, child, adolescent health, and nutrition services are kept going with the least disruption. These documents have been widely disseminated to all levels, and we are making increasing use of IT for information sharing, for monitoring and supervision. Scheduled delivery of essential medicines and supplies to the point of care ensures that stockouts are reduced to the barest minimum. Ghana has a drone service that serves hard-to-reach areas. Measures have also been taken for regular water supply to health facilities and communities. During the period of lockdown, a transport system dedicated to essential health staff was set up to facilitate commuting to and from their workplaces. Community health committees and community members have also been mobilized to support these efforts. Next slide, please. Zipline is Ghana's drone service. In this graph, we see the increasing number of vaccine vials that are being delivered through this service and the rising number of health facilities that are being served. Currently, more than 600 health facilities are reached by Zipline. Next. Now to the service delivery approaches. All routine services continue to be delivered with some modifications, and appropriate PPEs are provided for staff. The modifications include an emphasis on daily provision of services rather than using dedicated days of the week in order to reduce crowding. Smaller but more frequent outreach clinics have also been set up in communities to limit exposure of healthy children and caregivers to the risk of infection in health facilities. Face-to-face contacts are reduced by using phone calls for follow-up, and contact numbers of providers are made available for clients to call when necessary. Next slide. Now to strategies that are being implemented to maintain demand for services and promote household and community preventive services. Advocacy and public education have been heightened in order to generate demand for services. All available channels are being utilized, and our telecommunication companies are on board with SMS messages and voice calls when people make or receive calls. And trusted voices like the Pediatric Society of Ghana, as well as traditional leaders, are fully on board. This year's Child Health Promotion Week, which is commemorated in May every year, was dedicated to emphasizing the need to sustain child caring practices to promote healthy childhood, even in the face of the pandemic. Next slide. Next slide, please. Here are some examples of newspaper headlines that talked about the need to continue accessing child health services, and e-posters with messages from the Pediatric Society of Ghana that were broadcast using social media. Next. Next slide, please. Now, in the shot, we see an example of a banner at one of our sub-districts that was used during the Child Health Promotion Week in May. And we see the list of services that were being promoted during that period. May I have the next slide? I will now briefly share with you preliminary findings from a survey that started on the 2nd of June and which will end next week. 4 out of our 16 regions are involved, with over 20 health facilities targeted. Next slide. Next slide, please. In response to interviews, health workers confirmed their reluctance to deliver services initially. And they indicate that now service provision takes a little longer. Also, challenges in the health system that have been exposed include inadequate infrastructure, erratic supply of commodities, and a lack of emergency supplies like oxygen. Next slide. Next slide, please. In order to ensure the safety of clients and staff, various changes have been made at the facility level. And these include the provision of hand washing facilities at all entrances to health centers. Seating arrangements have also been reorganized with more use of the outdoors, and holding areas have been created for suspected cases pending their transfer to designated centers. May I have the next slide? There are still concerns among health staff, and their concerns range from limited staff strength, inadequate PPEs, as well as inadequate equipment. May I have the next slide? Initial results of the assessment have already been shared with relevant health managers. As we finalize the results, they'll be shared and disseminated to managers at various levels so that the gaps can be addressed. But meanwhile, it's been agreed that some capacity building for logistics management will be needed for staff at the lower levels to reduce the stock outs. Already, we are engaging stakeholders like the private sector and individuals in the communities to assist with the provision of PPEs and other logistics. And the response so far has been encouraging. Next slide. Now, in summary, the COVID-19 pandemic has exposed existing weaknesses in Ghana's primary healthcare system. Efforts are, however, being made to address these gaps in order to ensure continuity of service delivery. I believe that this is an opportunity, and once these gaps are addressed, we'll reap results that go beyond the period of the pandemic, and that will be more long-lasting. We've realized that investing in the safety of health providers and clients at service delivery points is really important for maintaining continuity of services. It builds confidence in our clients, and they are reassured that they are not at a risk of being infected by us. Communication with the public is also essential, and it will continue to be sustained and multifaceted so that we can have effective demand generation. We've realized beyond doubt that communities have a role to play. They have already taken up the mantle, and we hope to continue to strategically engage them to continue accessing our services. Next. Thank you very much for your attention.
Well, thank you very much, Dr. Sangamoses. I think that what Ghana's been able to do in terms of some very impressive planning and response, the innovations on the supply side, the emphasis on communications and building and maintaining demand is all very impressive. I thought one of your key points at the end was also really resonated with me, which was that COVID-19 has exposed existing weaknesses in our systems. And that applies both to primary healthcare as well as general issues that surround supply chain. And I think that we're learning more and more that this is going to help us in some ways to try to address and really target those weaknesses. So thank you very much. And we have one more country experience to share. And our speaker is Dr. Tom Sase, who's the Program Manager for Child Health and EPI in the Ministry of Health and Sanitation in Sierra Leone. Certainly, this is there's a Sierra Leone has had a number of challenges over the past couple of decades, and it'll be interesting to see how COVID has strained that system and what the response has been. So I'll turn it over to you now, Dr. Sase, and look forward to your remarks. Thank you.
Yeah, thank you very much, John. And I want to bring greetings from the leadership of the Ministry of Health and Sanitation as we share our experience as a country in maintaining essential child and immunization services. Next slide. Yeah, so basically I will briefly talk about the Sierra Leone health system, and then we'll look at the impact of COVID-19 on pediatric admissions and immunizations. And then we'll look at the measures that we are taking as a ministry, as a country, to maintain child health and immunization services. And then we'll look at some of the challenges we are facing and the mitigating actions we are trying to adopt to address those challenges. Next slide. Yeah, so Sierra Leone has basically a three-tiered pyramidal healthcare system consisting of about 1,300 primary healthcare facilities that attend to the majority of the population, about 30 secondary healthcare facilities, which are mostly the district hospitals, and we have about 11 tertiary hospitals that also mainly involve the university teaching hospitals. Next slide. Since the first COVID-19 case was recorded in the country on the 30th of March, the country has now recorded a total of 1,642 cases from all the 16 districts in the country. However, the testing rate in the country is low. We are doing about 1,850 tests per million population. And when you compare that with countries like Ghana that are doing like 11,389 per million, we still have a long way to go in our testing. Next slide. So the next slide, of course, shows the impact of COVID on pediatric admissions, which reduced significantly after the first 3 days of lockdown was imposed, together with night curfew. And we see, however, that admissions are now recovering, and by the month of May, we're saying that a very good recovery is happening. And that is something that we'll try to see how we can sustain. Next slide. We've also reviewed immunization data from January to May of 2020 and compared it with the same period in 2019. And it has showed reductions in total vaccinations in 2020. This reduction was most notable around the month of April, with about 17% reduction in 2020 compared with the corresponding period in 2019. However, improvements were observed by May, which is also a sign of recovery, similar to what we saw for the pediatric admissions. Next slide. So for some of the key measures that have been adopted to maintain child health and immunization services, we're looking at it from different levels, from the policy and strategy level, the tertiary healthcare facilities, secondary, primary, and community levels. We have established and reactivated treatment facilities and community care centers, most of which were actually built during the Ebola outbreak. And the fact that confirmed COVID-19 cases are being managed outside of general hospitals assures the general public about the safety of these general hospitals. Moreover, isolation facilities that were also usually built, mostly built during the the Ebola period, have also been reactivated and being used as isolation centers in the hospitals for suspected cases that are identified during screening. We have reviewed and updated various policies, guidelines, and job aids to guide service providers to adapt services to the context of COVID-19. Capacity building is also being done through training and mentorship of staff at various levels to build their confidence in handling patients. We are also using virtual platforms such as Zoom to engage with health managers at various levels in the health system. Next slide. We try to emphasize on physical distancing in health facilities, and some of the strategies we are using to achieve that include the fact that stable patients with chronic conditions are given their medications for longer durations, so that the visits are reduced to the health facilities. We are scheduling more frequent immunization sessions to reduce on the crowds coming to the health facilities. And we are also expanding on waiting areas in the health facilities and also establishing outdoor waiting areas where it is feasible. Of course, screening and triage is going on in all facilities to ensure that any suspected cases would be detected. And we're also trying to separate patients that come for curative services from those that are coming for preventive services. Next slide. Of course, we enforce IPC precautions by ensuring availability of soap, water, hand sanitizer in all facilities, regular cleaning of surfaces and floors, keeping patients in well-ventilated rooms, respiratory hygiene being observed, and then, of course, the rational use of personal protective equipment, and ensuring that patients that in the suspected or the isolation wards, suspected patients in isolation wards are kept well apart to prevent cross-infection. Next slide. We are doing monitoring and supervision of health facilities to ensure compliance to all the guidelines that have been developed. We are strengthening community health services by the community health workers, because in the event that the epidemic progresses and we have expansive community transmission, the role of community health workers to provide community services at the community level will become much more important. Of course, we are also engaging and sensitizing communities through various media channels, including the social media. And at community level, we are also using community health workers as community mobilizers to do house-to-house community engagement. Next slide. So of course, the next slide demonstrates an example of patient flow that happens in a typical child health facility. If you look, the clients would enter through the green corridor on the left of the screen, and they will be screened. And if they are not suspected of COVID, they will proceed to the extreme right, the blue region on the right, to access various routine services. And those that are suspected will come down along the red corridor to the area for suspected ward in red. And then after they receive their lab results, if they are confirmed to the positive, they get to the confirmed ward and for subsequent transfer to treatment facilities. Next slide. So regarding vaccination-related issues, considering the relatively low prevalence of COVID-19 from the available epidemiological data that we have, both static and outreach vaccination services are still going on, despite the fact that we are having reduced vaccinations. We provide guidance on physical distancing, and IPC is also being ensured. We undertake monitoring of the number and location of children that are missing out of vaccinations for eventual catch-up vaccination when the situation improves. Of course, we've submitted proposal to Gavi to support enhanced community engagement and outreach services for communities with marked reductions in vaccinations. Next slide. So regarding the challenges and the mitigating actions that we have, the main challenges we're facing are the fact that more resources are being channeled to COVID response at the expense of integrated routine essential health services, and the fact that health worker infection happens in some cases, which has led to closure of some facilities and maybe parts of some facilities along the line. Also, staff shortages for some services, specialized services, due to repurposing of staff to the COVID response. Sometimes we have challenges with water availability in some facilities. And then, of course, the poor health-seeking behavior of communities because of fear of contracting COVID. We are mitigating these challenges by the fact that the Ministry of Health has developed a non-COVID response plan. And also, the ministry is deploying an essential health service focal person in the COVID response so that it can link with the rest of the Ministry of Health. Also, we are training health workers on the provision of service in the context of COVID-19 on IPC and patient flow in facilities. Recruitment of additional health workers and providing training for them is addressing the staff shortages. We're coordinating with partners to improve on water availability in health facilities. And of course, we are engaging communities through various channels, including the community health workers, to ensure that we address the issue of poor health-seeking behavior. So, ladies and gentlemen, thanks for listening. In a nutshell, this is a summary of some of the actions that we are taking as a country to address child health and immunization services. So thank you very much for this.
Well, thank you very much, Dr. Sese. It's certainly impressive how far you've been able to reorganize services in a constrained environment to be able to ensure that the services can continue to be delivered safely. First, I have one more housekeeping note. I want to make sure that everyone's aware that the slides from these presentations, as well as a recording of the webinar, will be shared with all attendees following this event. So that hopefully that'll be very helpful to you. And now we're going to enter a Q&A, a panel discussion, where we will actually attempt to go off of audio only and have a video option for, I will moderate with the 3 country presenters. And we have a set of questions. We've been integrating and moderating and taking in the questions that have been put into the Q&A, and also have a couple of other questions that were prepared in advance. So we're going to move over to the Q&A part of this now. So with that, I'd like to pose first a question for all panelists. You've all described ways in which immunization first took a large hit, but then also recovered, and some of the work that you did to try to rebuild that. We know that immunization, even at the best of times, there are some enormous equity issues and challenges in reaching the rural, marginalized, and some of the most vulnerable populations. A question then is, who have you found as part of this recovery seem to be the most influential voices that you can use to reach those most vulnerable and marginalized populations? Is it the doctors? Is it traditional leaders? Is it political leadership? So I'll put that question on the floor to open, but then also a related immunization question is, with the effort to actually then encourage people to continue to seek these services, how do you actually ensure that you're not creating concentrations of people, mothers and children together, that can present risks in the COVID context? So open the floor and ask our speakers to address those as our opening questions. Who'd like to start?
Apologies, I dropped off briefly, so I missed some aspects of the question. Sorry about that.
Oh, okay. So just to briefly summarize, who are the best voices for reaching the poor and marginalized? And if you're successful in getting people to come for immunization services, how do we avoid creating risky gatherings of mothers and children? Okay. Perhaps Dr. Shamsul, maybe you'd like to start.
Okay, thank you. Welcome you everybody again. Our Honorable Prime Minister's engaging voice during COVID in various media platforms revealed public awareness, trust, and confidence. We have inspiring volunteerism services from doctors who provide consultation through mobile phones, helplines, and hotline numbers. These volunteers were given trainings to provide vital COVID and non-COVID information. And also the online social media platforms were used to create awareness for utilization of immunization services following IPC measures. And we have started virtual training sessions, and digital solutions were used for healthcare providers at multiple tiers for providing health services during COVID situation. Thank you.
Okay, thank you. Dr. Sagamoses, Dr. Sese, do you want to come in on this? Please.
Yes, John. We find that community members really trust health workers, doctors and nurses. So health workers have been some of the voices that have been used. But in particular, our Pediatric Society of Ghana, since everybody knows pediatricians specialize in the welfare of children, they have gone on the airwaves, they have gone on social media, and their voices have also helped to build confidence in the system. Additionally, we've made use of our traditional leaders At the lowest level in the rural areas and in communities, we have queen mothers and chiefs that are also trusted. They have come on board. And in our communities, in Ghana, we have what we call the community-based health and planning services, where we place health workers in communities and they are aided by community health volunteers who form a committee, and they help to mobilize communities around health activities. So the community health committees have also done a great job, and they are helping to mobilize people for the services. In order to reduce crowding, I talked about holding more outreaches. So where, let's say, there's one outreach point in the past, this may be broken up into maybe 2-3 outreach points. So there are fewer children and caregivers that are gathering. And also we are using the appointment system. In the past, it's been only given dates, but now we are adding time. So some caregivers are scheduled to come early in the morning, some come a bit later. And these are all in a bid to reduce the crowds. Thank you.
Okay, thank you. Dr. Sase, I think do you want to come in?
Well, yeah, I think to a large extent, our situation is not too different from what Ghana has already explained, in the sense that we are also trying to get fewer people getting to the health facilities at a time, rather than having, we are getting more sessions of immunization sessions and with less smaller numbers, you know, so that we can avoid crowded areas. And of course, we're encouraging health facilities to expand on the waiting areas, and so that children are attended to, you know, in smaller numbers in the health facilities, while having adequate spacing, you know, between the caregivers, you know, when they come to the health facilities. And of course, outreach services are also emphasized, you know, so that at the rural settings, you know, outreach sessions are organized for specific communities rather than them coming to the hospital. So these are some of the measures that we are adopting to reduce on the crowd that comes to the health facilities. Yeah, thank you.
Okay, thank you. Let's go a little bit further on the issue of outreach and talk a little bit about the role of small community-based organizations to help empower communities and connect them to health services. That was one question actually that came in from the floor. I'd like to start with Dr. Shamsul and talk a little bit about ways in which those kinds of organizations have been engaged to help support the effort to encourage communities to continue to seek critical care.
Thank you, John. Our other organizations with us, that is the WHO and also the UNICEF and USAID and also the Gavi, who are supporting us throughout the year, and also in these COVID situations, they are also with us. And these organizations are helping with our local organizations like our BRAC, and also the other ministries also are helping us, because our local government is a great part of our immunization activities. They are doing this in the, usually our immunization activities in the urban area run by our local governments. So we have a good connection with our local government, and they are helping us. Thank you.
Okay, thanks so much. Do others want to come in on this question? There's others, but just want to make sure you don't want to, you have no comments on this.
Yes, John. In Ghana, particularly in the northern regions, we have very active mother-to-mother support groups. They started off promoting breastfeeding, but now they promote other child welfare services. And they have been key in helping mobilize their colleagues. And the Queen Mothers I talked about earlier also have a network. There's one group that has a network across various regions. They came together and had some sessions to update themselves and we shared with them some of the health messages that we had developed, and they are also using these at the very lowest level in their homes and communities. Thank you.
Yeah, okay, thank you very much for that. Just a follow up, because actually it was an explicit question also in the chat, in the Q&A for you. In terms of even prior to COVID, there were children who were left out in terms of immunization, not as many in Ghana as in elsewhere, but there's always been challenges in reaching some of the most vulnerable and marginalized children. Do some of the structures that you've just described, have they also, do they have the potential to, in the face of COVID, just reaching some of these children, maybe for the first time?
So is that
Yes,
the general question?
they do.
Yes, that question was for Dr. Saga-Moses. Yes.
Okay. All right.
Yes, thank you. So the structures I mentioned do have the potential. In the lowest communities, our community health workers have registers where they know virtually every person within the communities that they serve, and they are able to follow and detect who is defaulting for which service. And then they work together with the community health committees to contact these people. In some cases, even during the COVID era, some of our health workers still conduct home visits, especially when they notice that a child has defaulted for immunization. So they go out to the homes and try to contact these mothers. The mother-to-mother support groups are great. They know each other and they know how to convince each other to access services. So they are really helping.
Okay, thanks very much. It's very inspiring. Let's turn to a slightly different issue. It's about the maintenance of routine reporting and how that may have been affected by the pandemic. So we'll start with Dr. Sese. This question came from the floor, which is, how is routine reporting been affected by the pandemic? Is some of the data on reduced utilization, could it partially be reflecting incomplete reporting into the DHIS2 system? And others think about that as well. Thanks. But Dr. Sese, over to you.
Yeah, thank you very much for that question. I think we have a very strong health information system in Sierra Leone. We are using the DHIS2. And to a large extent, most of the facilities we have in the country have continued to provide services. And virtually all of them have been reporting. The challenge has been the number of clients that they've been having. But the monthly reports have been coming, and we're not sure that the reductions we observed is because they are not sending reports. They are sending reports, but I think the numbers were severely hit in the early part of the COVID response. You saw in the graph that I showed that in the month of April particularly, there was a very heavy impact on all services because of hesitancy on the part of communities, and even the health workers were also not very sure about how to handle this particular situation they are faced with, So, but with all the interventions that are going into training of health workers, building their capacity, building their confidence, and reaching out to the communities, we see the situation changing. It has really not reached the level, the pre-COVID level, but it's encouraging that it's going up. And we're also working hard to ensure that the community transmission does not expand, because that would present another situation that as much as we want to expand services, we also we have to be cognizant about the safety of the health workers and the safety of the clients as well. So these are all considerations that we are having. But the health information system is good. We have copies. We have every health facility has a tablet. They send electronic reports to the district and then to the national level, and that is going on very fine. Thank you.
Thank you so much. Dr. Saga-Moses, Dr. Shamsul, do you want to come in on this question, or should we move on? Please feel free.
It's not very different from Ghana. We also have a very strong system, which is internet-based. And what I'd like to add is that we rank regions and districts on timeliness and completeness of reporting at regular intervals. And so they really try to keep up to date, and there are validation meetings built in all along the various levels. So we believe the figures we are getting are very near to complete. We don't think we are missing much.
Okay, thanks. Thanks for that additional perspective. Dr. Shamsul, any comments on this, or should I move on?
Yes, I can. Can you hear me?
Yes, it's fine.
Yes. You know that in Bangladesh, we have a good micro plan in the starting of the year. Each year we have done it, and in the month, each month we have a good DHIS2 system, and monthly immunization coverage is always in our hand. So we can find out the number of dropout and left out children. But in this COVID situation, when there is lockdown and the total system is disrupted, and you know that the huge population of Bangladesh, so we can, at the starting point, we have missed a lot of EPI sessions. But after that, we can mapping them by our DHIS2 system that which areas this is more. And after that, just we have started a supervision from our headquarters to contact with our local leaders or the local officers who are working with them, and find out, at least we have give them an instruction that to find out the dropout and left out children, and please list them. And in the month of May, you have done it, and after that, we have started our guideline. We have developed a good guideline, and we instructed the guideline to our local levels. And we also provided PPE for health workers. And after that, following the guidelines for appropriate social distancing for mothers at the immunization centers, by time gapping, we have instructed them, and the vaccination ensured by the vaccinator ensured no gathering and crowding. So this is after that we have done it, and at the end of May, we have seen that our immunization cover is now gradually increasing. So we think that within a few months we can find out the gap. We can complete the gap. Thank you.
Okay, well, thank you very much. One general question in terms of, it's important for both the safety of the healthcare workers, it's also important in terms of building and maintaining confidence in the safety of services to be delivered, is the issue of availability and use of personal protective equipment, PPEs. In each of your countries, have you faced any particular barriers and challenges in either obtaining or ensuring effective utilization of PPEs at facility level? I guess I'll start with you, Dr. Sese.
Yeah, exactly. The issue of PPE is actually a very major problem. And especially at the start of the outbreak, the numbers and availability of PPE was very limited. So most of the emphasis was providing PPEs for the treatment facilities and the isolation facilities in the hospitals, as well as focusing on the tertiary and the secondary hospitals. So there was a lot of shortfall in the availability of PPEs for the primary healthcare level, and that was a huge concern. But gradually, as I think now the numbers, the availability is getting better and PPEs are being provided. But what we are now emphasizing on is the rational use of PPEs. There was a time when at the early part of the COVID response, we saw the general public all using medical masks all over, and of course that's created serious anxiety about availability for health workers, So all of that now is being handled, and the emphasis is now, communities are now using cloth masks, because the general policy now in the country is that everybody should be wearing masks in crowded places. So, but cloth masks are being encouraged. And the Medical Dental Council Association also came up with cloth masks that can also be used in not highly infectious healthcare settings, that are relatively safe, not at the level of medical masks, but they can also be used in some healthcare settings as well. And that has been helpful in providing rational use and ensuring that health workers do not use the PPEs when not necessary. So for example, in those that have isolation facilities, they will try to do what's called bundling of interventions. When you go at a particular time, you do multiple interventions in the isolation centers, and then you come out, rather than having people going at each visit and changing the PPE. And that, of course, was causing a lot of a shortage of PPEs. And then, for example, gowns, there are a lot of reusable gowns that are now being used, of course, washable gowns that could be reused. And these are all strategies that are being employed to ensure the rational use of PPEs. But it's still a challenge, it's still a problem, especially at the primary healthcare level. And that is something that the ministry is working on to address. Thank you.
Okay, thank you. That's clearly a challenge. Dr. Sagamoses, Dr. Shamsul, do you have anything to add on this question?
Yes, we've had similar challenges to what Dr. Sese has outlined. And for us, once we got the guidelines in place and disseminated to managers, it helped with including frontline staff for preventive services in the distribution, because initially they were not being prioritized. And what has also helped us a bit is there's now local production of some PPEs. So it's helped to improve the numbers, and appeal to corporate bodies and other private individuals has also yielded some results, but we haven't completely gotten over, although the situation has improved. Thank you.
Okay, thank you.
Dr. Shamsul, anything to add further?
Yes, nothing to be added, all the same, but for the situation for the hospital is different, but the outreach center is like that. At the initial phase, it was very much, there was very much a scarcity of PPEs in the field level, but now we are trying to overcome the situation, and our field workers are using the face mask like this medical mask and sanitizers for the immunization center, outreach center regularly, and also they are maintaining the social distancing in the EPI center. It is helpful because the mothers and child there, I don't know whether he or she is COVID or non-COVID, but social distancing, sorry. Social distancing is a good method for them. Okay, thank you. Sorry.
Okay, thanks. Yes, we all face challenges of background noise, so no problem. Turn to another question for Dr. Sese. This came from the floors. There was interest in what you laid out quite explicitly about the green zone, red zone. How do you determine which patients go to the green zone and who goes to the red zone? Is that triage just based on clinical symptoms, or do you actually have a way to turn around laboratory results very quickly?
That's a tricky one. Unfortunately, we don't get the lab results very quickly. It's mainly based on clinical assessment, and those that are suspected get to the suspect ward. But a lot of attention is paid to ensuring that the turnaround time for getting the confirmation is quick, and there's a lot of separation of the beds in the suspect wards, and very ensuring that there's no interaction between the beds, and I mean, even the services being provided by dedicated staff to specific patients in the suspect ward. So a lot of emphasis is paid to ensure that there's no cross infection, but usually within 24 to 48 hours, the confirmation will be available, and then those who would get to the treatment facility or those who go back to the normal services will go back to the normal services. But that's the situation as of now. Yeah. Thank you.
Okay, thank you. A question for Dr. Sagamoses. So has there been any consideration at that primary healthcare level of using appointment systems or maybe otherwise scheduling routine services especially at the health centers, or even in terms of community health outreach, community health compounds for in places where COVID is especially an issue? Has scheduling been part of the response, or considered as part of the response?
Yes, indeed, scheduling is part of the response. So formally, clients will be scheduled just based on the date when they should come. But now we are adding time. So initially, everybody expects to come in the morning if they are scheduled for a particular day. But now we've added time schedules, so they don't all have to come together at the same time. So that appointment system has been helping. And also for the outreach points that have been divided into 2 or 3, they are told they don't all operate at the same time. So the numbers are divided between the number of extra outreach stations that have been created and when they are expected to operate. Thank you. But then I must mention that there is still a challenge with that, because clients are not used to the appointment. So health workers have complained about them still coming like before. And once they show up, it's difficult to say, no, you go and come in the afternoon. So we are still trying to work around that. Thank you.
Well, we all know that behavior change is one of the most difficult things to actually accomplish on part of both providers and on top part of care seekers. So that actually would be a good segue into a question for Dr. Shamsul, which is, so you have some very effective communications activities. It seems, both the ones that you're doing in terms of the phone services and information, as well as just the general awareness raising. For those kinds of communications activities, how well do you know they're working? I mean, you know what's been going on and what's been provided. How much do you know that they've actually had, what impact that they've had on behaviors and outcomes? Are you seeing the kinds of results that you want in terms of increased care seeking, and do you think those are attributed to that outreach and communications? Over.
Thank you. Yes, during this COVID situation, it's a great challenge for us, but we are trying our best, and from our central point or like this, we are regularly doing the Zoom experience with our local managers or like that, and we are giving guidelines to them for this situation. And after that, we are trying to from our headquarters side, also the local side, to visit the places, because though the situation is it is a hard situation for us, but we are trying from our side to regular monitoring of these programs or like this, like our EPI centers, also the hospitals, also the outreach centers. Thank you.
Okay, thanks so much. We only have a few minutes left for the Q&A, and I'd like to turn attention to something that's come up in a couple of different questions from the floor. And it's the potential for any kind of remote consultation, remote medicine in the settings in which you're working for populations that might not otherwise have access to services. Are those kinds of remote services, what we refer to often as telemedicine, are they feasible, and do you think they would actually have impact? So I'll leave that open for any of you who would like to come in first. Maybe Dr. Sese, because we've been rotating around our panel, so you'd be next.
Yeah, thank you. Yeah, I think that's a very interesting proposition, and it's something that we cannot only think of at the moment. We don't have, it's not happening as yet. But like I said, we have a separate outfit that has been set up for COVID response, separate from the general health services, So, but now that we have an essential health services focal person in the COVID response, we are better now able to interact and interface with the established outfit for COVID-19 to see how we can embed some of these issues into the response. But at the moment, like I said, it's a good proposition, and it's something that we would look forward to learning from experiences from countries that have this kind of structures and see how we can implement it in Sierra Leone. Yeah.
Okay, thank you. Dr. Sagamoses, do you have any comments on this and the potential in Ghana?
Yes, we have just about started. In the last couple of years, the Ghana Health Service has been exploring telemedicine in general. And so, but it's mainly in our larger cities and specialist centers. And in addition to services being provided to clients by phone and so on, it's also being used for specialists to provide support to caregivers who are less specialized at very remote areas. So they are linked to specialists by phone or by WhatsApp, and they are able to communicate to them when they have difficult cases. Sometimes even before referral, there are WhatsApp platforms that are used to discuss the case and suggestions given by specialists about what can be done for the patient before they are referred, or even sometimes with the intervention, they no longer need to be referred. So we've just started exploring, and we hope to expand it. Thank you.
Can I say something that?
Yes, please, go ahead.
During my presentation, I have informed that we have 4,000 doctors who are giving voluntary phone services daily, and they are working with us, and we have already developed the telemedicine services few years back. About 58 centers which are working for telemedicine services in Bangladesh now. And regular phone call is also available by our central monitoring cell. These services are available now. So from this side, we are providing services. Thank you.
Okay, well, thank you to all of our panelists, Dr. Sese, Dr. Sagamoses, Dr. Shamsul. It's been a really stimulating both set of presentations and discussion. From where I sit, the Global Financing Facility, all three of our countries are amongst the 36 in which we're working, trying to work with the World Bank as World Bank has in turn engaged very heavily in COVID response. And the projects coming on board now that address COVID really do take on board this threat of COVID to essential services in addition to the threats posed by COVID directly. So all these inputs are really welcome. I know that I've learned a lot, and I want to thank you for your participation and your presentations today. We didn't have the time to actually address all the questions that came in from the floor. So the organizers will be in touch following the webinar. They're going to distribute the recording and the slides, and they will try to address some of the questions that we didn't have a chance to get through today. So please, I'm sorry that we weren't able to get through all of them. Time was just too limited, but we did get through a lot of them. So hopefully you've got some of the feedback that you were looking for. So with that, I'm going to turn it over for closing remarks to Dr. Haque Agarwal. Haque and I have known each other for quite a long time now, and she is the project director for USAID's Momentum Country and Leadership Project, and has a long-standing career and is an internationally recognized expert in maternal health and reproductive health. So over to you, Haque, for wrapping up. Thanks very much, and it's been a pleasure.
Thank you, John, and thank you to all our panelists and John and Steve for discussing today. As our panelists have demonstrated, countries are reimagining routine child health and immunization services in order to maintain them under these challenging circumstances. Integrated child health services and immunizations have traditionally been provided and prioritized at lower tiers of health system, although they are provided at all levels. They remain very, very essential services, and despite the shifting attention and resources to national COVID responses, we need to make sure that they are continued and provided to the individuals who need them. As the health systems and countries have faced increased cases of COVID, the delivery of some of these routine child health and immunization services have suffered, but must continue in communities and the first level facilities, or else we risk rolling back decades of progress in the fight against under 5 mortality. As Steve put it in his comments today, low and middle income countries should think differently than those more developed and prioritize the continuity of curative and preventive health services to ensure the greatest health benefits at scale, ensuring equitable access for all. Our panelists gave a snapshot of what it looks like on the ground, including some highlights. For instance, from Ghana, we heard the focus on the last mile delivery of essential medicines, including vaccines, even by drones. And from Sierra Leone, we heard about the reorganization of patient flow to allow for child health visits to continue. And from Bangladesh, we heard the importance of developing national guidelines and disseminating them for the national COVID response with MNCH and immunization services. These were just some of the means that these countries highlighted, but countries are using to mitigate the impact of pandemic on the health of women and children. In all of the examples shared today, strong strategic planning and country leadership are essential to maintaining and improving access to services, while also ensuring that these services are of high quality. I would like to thank all of our presenters for sharing their experiences and the attendees for so many wonderful questions. We will not, as John said, we were not able to address all of them, but we hope to reply to many more in a post-webinar and email to follow with these discussions. Thank you again, and stay tuned for more in our ongoing country knowledge exchange series hosted by USAID's Momentum Country and Global Leadership. We look forward to continuing this discussion. Thank you.